We actually had a professor back in school refer to this as a dirty drug. And to double down on that, now we're seeing that there is a greater risk for harm. So not only is it not really working that well, but now we can kind of say with moderate certainty that tramadol has the potential to, based on this study, double the risk of serious adverse effects.
This is Generation Health. We bring the latest news, cutting-edge research, and time-tested best practices, helping you live a longer, healthier life. With me, Dante DiMatteo, PharmD. How are you, my friend?
Pretty good. How about you?
I'm good. I'm very, very good. Josiah Schweinberg, microphone number 123 today. He can't even hear me because you just got your
I got a
headphones on.
promotion.
Yeah, well, I mean...
Mic 3.
That's it. When somebody drops off...
You're next up.
Look out, Dante. He's coming for you.
I got a promotion not because of my skill set or ability.
That's correct. It's
but because of the unavailability.
It's like government. When you just hang out long enough, you'll get a promotion.
Here I am.
Okay. This is, we're going to talk about a really important topic. This is big news. Tramadol is often thought to be a very safe opioid. It's the safer opioid. I don't know that they market it that way, but that's the way it's thought in a lot of crowds because it's a little weaker, generally speaking, than some of the others, right? Is that a good way to say it? 16 million prescriptions every year in America. That is a lot of people taking this drug, but a new meta-analysis, very rigorously done by Emiejcacy and colleagues, suggests that it is a fundamentally flawed way of looking at things and honestly pretty dangerous. Mm-hmm. So what's going on with this? Who all's taking it? Tell me some of the basics.
So some of the basics, tramadol, again, like you mentioned, its perceived safety profile is because of its multiple mechanisms. So if we're just looking at briefly how it works, it's part opioid or painkiller, basically, as many people are familiar with, part SNRI.
Okay.
It has been given this reputation as a weaker opioid and this lower perceived risk of dependence compared to some of the other Schedule IIs. And I think this just was a little bit of a, insidious thing. So now here we are years and years later. It's, some of the prescribing of the other Schedule II opioids may have decreased.
For sure.
And now you have ones like this that have, tended to stick around, at least according to the research and what we can sort of see in practice.
Yeah.
So again, it has multiple mechanisms of action. We actually had a professor back in school refer to this as a dirty drug, and not in the sense that you would where your head first goes
it's full of pollutants or anything like that.
Right. But again, just because it has it's doing a few different things.
Okay.
And
so it's not as targeted.
Right. Right. And so in some cases, this is good. In other cases, this is bad. This is bad because you might have somebody who is already on different antidepressants. They're on different medications that are being metabolized by the same pathways and cleared by the same pathways. And then you factor something like this into the fold that requires all those different pathways, and you have the potential for some actually meaningful drug interaction. So that's the gist of it. It's historically just been used as a way for patients to manage pain.
Okay.
All right. So I think that's at least the background on tramadol.
Yeah. Who all is taking it at this point? I mean, we're not talking about surgery recovery, right?
It can be.
Okay.
Yeah, it can be. It's used in, chronic chronic pain.
It is still.
It is.
Okay.
Yeah. Yeah. And then the issue is, as is the case with many opioids, once you start taking them, it is just harder and harder to eventually taper off. You eventually will require a higher dose to achieve the same effect. And it's this kind of whole vicious cycle, difficult situation to be in. Your perception of pain is even a little higher maybe than when you started it. So it is just a lot to unravel.
Dang. All right. So tell me about this study or the meta-analysis.
Mm-hmm. So this was a classic example of, if you were to just quickly glance over this study, there was a statistically significant reduction in chronic pain with tramadol use, but the magnitude of the actual magnitude of the effect was so low, based upon how they're measuring it, pain scales, etc., that this benefit is clinically meaningless.
Interesting. So it's
statistically significant, but clinically, it's not really moving the needle as far as what people are looking for in these reduction of pain symptoms.
And certainly in a risk reward analysis, that's questionable. Okay.
Yeah. And to double down on that, now we're seeing that there is a greater risk for harm. So not only is it not really working that well, but now we can kind of say with moderate certainty that tramadol has the potential to, based on this study, double the risk of serious adverse effects. And this is the main two that were sort of parsed out were an increase in cardiac events and also neoplasms.
What is that?
Neoplasms are, it's basically just in reference to excessive growth tissue. So excessive growth of tissue. So this could be cancerous cells. This could be benign, non-cancerous cells, but any sort of, it can be used interchangeably with tumor.
Okay.
At times, but something that was not suspected.
Right.
There wasn't a great association up until this point with cancers. So now that they're
seeing that.
Yeah.
Oh man. So let me take you back to the perceived efficacy for a second. You said it was statistically significant, but not sufficient to justify the risk. What were they comparing it to?
They were comparing it to simple non-opioids. So think of Tylenol.
Okay.
And it was not working even as well as those types of medications were.
Wow.
Yeah.
So really not justifying its risk factors at all.
Yeah. And it's not that Tylenol and those over-the-counters are without risk.
Right.
But I mean, it pales in comparison at this point.
So it's not actually safer.
It's not.
And people are becoming dependent upon it and having the same issues as all the other opiates. Gum, that's frustrating. I want there to be a better solution.
It is. And again, it's really, it's not, this is not to scare people who are taking it. I assume this is a conversation that we're front running with patients. Those that can stay up to date with this sort of information, or they're who knows? It's probably a matter of time before this is on the news.
Sure.
To be honest, I would have to say. So I assume it's going to come up. I think there's a really thoughtful way to have this conversation with a person. It's not to scare them. It's not to say, "Oh my goodness, look what's going to happen to you." It's just maybe some of these people maybe they had some of these issues that didn't really amount to much. Maybe they're not on a ton of other medications. Maybe they're not experiencing these drug interactions. And again, we're looking at in studies like this, we're looking at like the average effect of all of these medications and the average on how well they're working. There's some people that this is going to be adequate in controlling their pain. And then there's going to be some people where this is like way off base. And then you're going to have people who have 20 years of no issues. And then people within 2 years, they experience issues.
Sure.
So, but it does call into question when just this idea, that the sentiment that comes up in conversations with patients, they'll say, I'm due to look at my medications with my doctor. I just need to look at my list. I'm on these 6 things, and sometimes I forget why I'm even taking these last 2.
Yeah.
And it happens. And, we all like to put things on autopilot, and I get it. And I would say for the most part, people will have that conversation with their doctor and not a whole lot changes. And that's fine. They stick with their working mix of meds and great. But then for other people, this might be a good opportunity to say, "Hey, I've been on tramadol. It's working, but now there's some emerging evidence, and I'm getting older, and I want to, if there's one thing maybe we can talk about removing, maybe it's this. Maybe we can explore some other options, and just reopen the discussion around the choice of pain management agents."
Okay.
It'd be good if there was just a chart, like a comparison chart.
Yeah.
Like here are the benefits, risks of, tramadol. Here's what Tylenol.
Yeah.
Or, then it's like, oh, well, when you talk about risk reward, or, that kind of like, well, let me see exactly, which I don't even know that they could spell it out that clearly.
But that is the ideal is to be able to look at it all and just go, oh, well, this makes the most sense. I'm willing to accept this much risk. You know,
and I don't know if you're going to talk about this, so sorry if I'm jumping ahead, but like the risks of like, so if someone decides they have that conversation with their doctor and they're like, you know what, I'm going to wean off or get off tramadol and start using, Tylenol as needed. Like, what are the effects, long-term effects, or the effects or withdrawal symptoms of getting off of that?
Yeah.
So I don't know if you're going to get into that, but that's
not necessarily, but I think that brings about a really good talking point in that, it's easy for us to say and talk about this.
I'm not currently in pain.
Right.
Correct,
This is if I'm giving off the vibe that I'm oversimplifying this entire thing, then I apologize. That's not the intent.
Right.
This is just, again, to spark maybe let's see what happens. Let's see what happens if we begin to taper. Let's see what happens if we begin to try some different agents. Let's see what happens if we mix this with I might start going back to PT for this specific issue. Or this just has to reopen the door to all the other options, because again, for the vast majority of people in the game of averages, this is not really working that well. It might be doing a little bit of something, but hey, this isn't just an opportunity. And it's not to pass judgment to this drug's going to be around still for a long time. It's not, people will continue. It's not to pass judgment. The process of tapering off medications like this, the process of tapering off antidepressants or any sort of medication that you can, theoretically build tolerance to, can be challenging, some more challenging than others. And so that is a whole other issue that you need to take very seriously with your provider. Absolutely.
Yeah.
Like a 2-hour, 2-hour podcast segment would not do it justice to the individualized discussion that would need to be had around that.
Wait a second.
So
this is going to be 2 hours.
well,
and that's it for us today.
Yeah.
All right. So we talked about the neoplasms briefly, the cell growth, or I guess kind of tumorous growth. You mentioned cardiac risk as well. What are we talking about there?
Looking at the cardiovascular risk, we're basically just saying that they've seen that people using this medication are potentially more likely to experience heart attack, stroke.
So the whole gamut.
Yes, those sorts of events.
Okay.
So this just gives the clinician a better starting point to say, hey, let's just understand what the person in front of me, do they have congestive heart failure? Is their hypertension controlled, uncontrolled? Hopefully it is. But again, just to say that, hey, we almost have like a contraindication now in starting this in somebody who might have some of those. So if we have a patient who already has those issues, again, it's just on the provider end of things, maybe we just maybe turn up the pressure on making a possible change like this. So there's I don't really see that there's a specific mechanism by which these are causing cardiovascular issues. I mean, there's some plausible thoughts behind why. Again, we mentioned the SNRI properties. So it selectively inhibits the reuptake of norepinephrine. And this basically can leave a little more norepinephrine floating around, which can increase your sympathetic tone. It can increase your heart rate. And so this sort of, increase in those things in this specific population could be leading to some issues.
It sounds like this is kind of related to when you said the professor calling it a dirty drug, that it's a potential side effect that's potentially intended side effect, but that a lot of people aren't aware of that, and that it can very easily sneak in there and cause issues when folks are totally unaware that that's even something they need to watch out for.
Exactly. And then the other layer is even the effect on kidney function, or somebody's kidney function going into, starting a medication like this. We know that this drug can lower the seizure threshold. So it's important that providers are checking, kidney function going into this. And, if somebody's is in a position where their kidneys are compromised, chronic kidney disease, whatever the case, this could increase the amount of drug essentially that accumulates, since you're not as effectively clearing it, therefore potentially leading to the occurrence of these events.
Yeah.
So
Yeah.
a lot of that is already known around this class of medications, but again, it's even more of a pertinent consideration at this point.
Okay. So the big takeaways here, it sounds like, are this is not the safer opiate everybody thought it was. It's not even as effective as everybody thought it was. And for most folks, you want to take a look at perhaps moving away from it and trying to find another solution for your pain. Is that a fair assessment?
Definitely.
Great. So let me ask you this totally unique question. As a pharmacist, is this a conversation you have with somebody when they show up with this prescription? Or is this one of those things where people really need to be advocating for themselves with their doctor?
Yeah. So that is a great question. I think it has the potential to go that way. Again, you would hope that the person bringing the prescription in, you have an established relationship with. It depends. You kind of got to know who you're talking to.
Right.
If somebody came in cold off the street and they're starting them on Tramadol and they asked for my opinion, then this sort of what we've been talking about in a thoughtful way would definitely come up.
Okay.
It definitely would. Now, am I going to go out of my way to Jane Smith, who's been coming in for 40 years to talk about her Tramadol? No, we're not. I don't think it's to that point.
Right.
So it certainly just depends. And for as willing as they are to talk about this, yes, this definitely ramps things up. It puts this medication a little more on my radar. It's not always that these topics are, applicable the next day in practice. Again, this is something that we kind of already knew. In a pharmacy role, in a retail end, you sometimes struggle to make an impact in this realm, maybe as much as you'd like to, but I will definitely use the opportunity as it presents itself to, at least open somebody's eyes to other options.
And self-advocacy is always preferable. That's always what we want to point people toward. But it is good to know that this is why you have to pay attention to all that new research, because this is the sort of thing that can really help people or harm them, as the case may be.
Right. And it's like at this point, it's like of all the choices, we're seeing that it's flawed thinking that is often leading to prescribing this medication potentially. It's like, well, we're not going to jump right to said painkiller that it sounds really scary and is more of a potent opioid, and so we're not going to do that. So we'll just start with this one.
Yeah.
And this will be a little less bad.
This is the training wheels.
That it's just that way of thinking now. I think this just kind of begins to move us away from that.
Good. Very cool. All right. We are excited. We've talked a lot about bone health, osteoporosis, osteopenia. We did multi-part episodes on it before, going deep on all of those things. But we're back here again for two reasons. One, it's a major, major issue and we can never cover it enough. And two, because we have a couple of new products and they slide into this whole conversation and kind of change the way we can address them for folks. So we're not just talking about, the same things we've covered a million other times. We got some new stuff specifically about bone health and bone density and what's going on, philosophy and supplementation in particular.
Yeah, where it can fit in.
Okay.
Yes. We always want to emphasize that's not the answer, especially with a topic like this. Just where does it fit in? Where does it make sense? Where is it going to actually help you? And make sure you're not missing some of the other key components.
Cool. So to that end, calcium. And that's it, right? That's the end of the conversation.
Exactly. You
take
got
calcium and that solves the problem.
600 milligrams twice a day and you're all fixed.
No, that's not the point. That's not how it works, unfortunately. Go ahead.
So, first, just want to explain a little bit about how bone actually works, okay? So remodeling is what's really critical here when you're talking about bones. They're not they seem like static structures, but they're constantly being remodeled.
Yep.
So there are cells called osteoclasts that break down bone. Osteoblasts build new bone. Our peak bone mass hits at around age 30. And a critical part here to understand is that estrogen decline actually accelerates the resorption. So estrogen decline increases the rate at which osteoclasts are functioning and the bone is resorbed out of the body, kind of the breakdown. So that's one of those things that obviously there's nothing you can do about as we age. We'll touch on HRT a little bit later, but that's what's going on. That's why you see it occurring, particularly in women as they age.
That's why it's more of a problem with the female side of the aisle. Okay, got it.
So what are you concerned about with bone health? You're ultimately concerned about fracture risk, okay? What goes into that? Bone density, bone quality, muscle strength, which is not one we think of, as well as hormone status, okay? So if there's a hierarchy, if we could do like a little ranking, because again, of course, we are deeply involved in supplements, and we do talk about resistance training a lot. So kind of putting everything together, what would the hierarchy be in terms of importance for bone health? Number 1, resistance training.
Yep.
Okay. 2 is protein intake. We'll go in a little bit more into why, but that's critical. Not something that comes to mind right away.
Right.
3 is hormonal optimization. That one's a little more complicated. Obviously, you'd want to get levels tested, et cetera, make sure that it's appropriate. But as we just mentioned, the hormonal status is a critical component of what's going on with the bones. Number 4, vitamin D sufficiency. That's one that's commonly checked. You can see where you are. You're not guessing. 5, another one that's a little under the radar is magnesium sufficiency. That really has to do with the architecture and the quality of the bone. Then 6, you get into calcium.
Wow. All the way down at number 6.
Yes. There are certainly other specialty agents, strontium, things that we'll touch on, trace minerals, K, all important. Though that's the hierarchy, science-based of where these things fall. Calcium is typically the easiest one to hit. It's just what's been around forever. And yes, of course, it matters. We're not sitting here telling you calcium doesn't matter. It's critical. But in the hierarchy of all these things, given the likelihood that you have a true calcium deficiency, it's not very high. It's very unlikely that you're truly deficient. So just ramping up more is not going to overtake those items that we mentioned that are higher in that hierarchy.
Okay.
So why is basic OTC calcium not enough? Okay. We can kind of address the Costco, Walmart style questions.
The big box.
I walk in, it's Oscal. My doctor said to take calcium. It's $10. Why not? If you have a true deficiency, that will help you. Point blank. But if you don't, and you've had a scan done, maybe God forbid you broke a bone, something is leading you towards understanding that bone health is an issue. The odds of of a true calcium deficiency being the answer are very low. So what are your options? Just to cover quickly, there's calcium carbonate. That's the cheapest. There's calcium citrate. That is a little bit better absorbed. So if you are going that route, stick with the citrate. And then they typically are going to have a little bit of vitamin D in there. Again, that's great. That's fine. Cover bases, but you want to get your level checked. There's no magnesium. There's no K2. So essentially, there's no remodeling influence at all. When you take just a straight calcium and D, you're basically just giving the body the bricks. You're not doing anything for your body in terms of how does this bone get modeled? How does it get put together? What's the quality of it? Okay?
So to that end, and what you were saying is that most folks don't actually have a legitimate brick deficiency in this case.
Yes.
That most people have enough calcium. It's just not being recruited properly, or it's being broken down faster that it can be remodeled. So those are just piling more bricks into this work site isn't going to get the house built.
Correct.
Okay.
With the emphasis on a true deficiency, it will make a massive difference.
Sure.
But that's not everybody, like you said.
Okay.
So just to continue on, a little bit controversial, but still a big part of this is there's so much mega dosing of calcium, of high dose calcium, that there are studies that suggest there is an increased risk of MI or heart attack with that high dose calcium.
Oh.
Why? In the most broad sense, what can occur is, especially without any of the kind of the K2s and the other remodeling agents, is that the calcium can build up in the blood and cause an issue that way. So again, there are plenty of studies come out in the last few years that show that maybe not only is this not giving the benefit to the bones, that the risk reward is way off, because now there's been this new risk we've discovered, and the reward in those without a deficiency is pretty low.
Okay. So where we go from there?
Yeah. So again, calcium alone fails. Bones need magnesium. You need vitamin D to absorb it. You need K2 to send it to the bone. Okay. And you need some mechanical stimulus. You do need some strength training, some moving, just getting your body to understand that it must make a more firm and strong and sound structure.
That was one of the big punchlines from our big osteoporosis, osteopenia, back-to-back episodes. One of the big punchlines was impact and resistance training are critical because they tell the body these need to be stronger to support what we're doing.
Exactly. Now. It's the body adapting. Exactly.
Got it.
So now where does a higher quality supplement come in? Something like our bone-based essentials. Okay.
This is one of the new products.
Yes. And just so we're clear, it's foundational. Okay. Because I'm going to name some numbers here and ingredients, and you're going to say, well, what about this? I heard this much. And what about my level? There's a reason for it, and we'll get there. So this is foundational in the sense that it's mineral optimization. It's making sure that you're covered, but it's not anabolic. It's not going to help build the bone. It's not interventional. Okay. It's covering the bases to make sure that moving forward, you're in the best position to not have those issues.
This is defense, not offense.
Yes. Yes. So what is it made of? 300 milligrams of calcium in absorbable forms, the hydroxyapatite, dicalcium malate. 300 milligrams of magnesium, critical for the structure, often overlooked. Okay. 1,000 IUs of D3, not a mega dose. If you have a D3 deficiency, you're going to need a lot more, but that's purposely in there at a moderate dose so we can have some impact. We're covering deficiencies, but we're also not overloading a situation so that, well, maybe I can't take this product because my D level is really high, or I've already addressed that. So it's got a low amount. 45 mics of MK7 form of vitamin K, highly absorbed form, longer acting form to make sure it stays active in the body. Bone remodeling goes on essentially all day in the body, okay? So there are studies done at higher doses. You may say, well, I read this study at 180, you've only got 45. Again, it's on purpose. There are certain situations where you don't want to take that much K. So this is covering the bases, making sure that you have it on board, that you're not deficient. If any one of these is truly deficient, you supplement individually, okay?
Got it. That's fantastic. Okay, but this is a great basic product. Okay, keep talking.
Yes. So a little bit more into the magnesium. It's probably what I would say is the most underappreciated and misunderstood mineral in bone health. And it's because our bones are not made of the magnesium. So it's not the bricks. It's got more of a managerial role, a regulatory role. It helps activate vitamin D, which is critical to the absorption. It helps to balance your parathyroid hormone, which also has an interplay with vitamin D and thus the calcium absorption.
Yep.
It also helps with crystal formation, so the quality and the way that the bones are being made. Okay, so it's not as black and white as, we look at a scan and we understand the bone is made up of X percentage of calcium. Magnesium's not in there to nearly that degree, but it's critical from a one step removed standpoint of its regulatory aspect. It's critical.
Sure, and magnesium is I know an issue for a lot of folks having lower magnesium than we should.
Yes. Vitamin D, we've touched on that many times over the years. This is a maintenance dose. Get your lab checked. You want to be between 40 and 60. This is just covering bases.
Okay.
K2, what does K2 do? So it activates osteocalcin, okay, which helps to build the bone. It basically is telling the bone we need to build more, telling the body we need to make more bone. Okay. It supports vascular protection. Okay, so it's cardioprotective at good doses, at right doses. All right. So it's not a therapeutic megadose, like I said, but it is enough to kind of cover the bases, make sure that it's on board for you for the quality of the bone that you're trying to maintain and to build.
Okay. All right. And specifically then, who is this for? It's fundamental. It's foundational.
Mm-hmm. I would say 40 plus.
Okay.
For prevention, for very early osteopenia, where, a medication maybe hasn't been recommended yet, and just for long-term maintenance. Also, a critical point is that this can, if you are on a medication and maybe you are taking an Oscal, basic calcium with it, this is the one you'd go to. Okay. So we're going to talk about a supplement that is more interventional. You'd say, well, I have osteoporosis. Why don't I do that one? You've got another thing cooking there in terms of what's doing the remodeling and how it's working. You don't need to add a higher level one. If you do have osteoporosis, we would recommend bone base to go along with the med.
Got it. Okay. All right. Well, then you said there's another product. That's the
Yes.
Bone Pro.
Yes. So
Okay.
now we're moving kind of out of the foundation aspects and we're moving to remodeling influences. Okay. So we're trying to we have a documented deficiency or lack of bone density. So how do we help to begin to move the needle on that? Okay. This product is built around strontium. Okay. There's 1,000 milligrams of strontium. Strontium is incorporated into the bone. Like we talked about, magnesium is not. Strontium is. Strontium stimulates osteoblasts, the bone building cells. Okay. It also reduces osteoclast activity. Okay. So it's hitting it from both ends. All right. So strontium, we know for those reasons, does have an effect on bone density. One thing to be aware of, though, again, we always want to be full disclosure. If you get a DEXA scan done, especially maybe it's in the early phases of when you've started this, strontium is heavier than calcium. So your early DEXA scan readings can be, I would say, artificially increased by 8 to 15%, it's estimated.
Oh, wow.
So just be aware, big picture, that you're going to almost get a quick bump because the strontium will be incorporated into the bone at higher rate for somebody who's on a product like this and who is not. But that's not yet improving the quality. You want to get up over 10% to really see the difference. So it's just a nuance to be aware of, again, from a full disclosure standpoint.
Got it. So if you take it and you get a quick DEXA scan, it'll look like, hey, you just did it. You solved the problem. Not really. Give it some more time. Keep doing the things. And
try to get up over those numbers that are kind of really, it's just the weight increase that's making the difference, not necessarily how many bone cells are there.
That's amazing. Okay, so strontium is the main differentiator. Is there anything else, or is that it?
Yes, we still have essentially all the items that are in bone base. Okay, so we're still covering bases there. What this one also does add, which is the magnesium, calcium, K2 and D.
Yep.
All right. We also have boron and trace minerals. Again, it's just a level of sophistication. Those are not incorporated into the bone. So why are they here? Well, these trace minerals and boron help to reduce urinary calcium loss. Okay. There's also kind of a secondary role in hormonal support.
Okay. So there are a bunch of extra little things in here.
Different
little things.
Different mechanisms.
Big things that are all meant to build it together. Okay. Who is this for? You said this is the Bone Pro we're talking about now.
Yes. This is for progressive osteopenia. So
Okay.
not full-blown osteoporosis, but little earlier phase things are progressing in the wrong direction for you. This is for people with osteoporosis, assuming they have decided to decline a medication. That is not what we're saying it should be for, or that you can replace your medication with this. That's not what we're saying. We're saying that if you have made that decision independently to not take a medication, what is the best option for you supplementally on top of the lifestyle things that we've mentioned? It is the Bone Pro.
You are a pharmacist and you do believe in pharmacology. Got it.
Yes.
But
yes.
if you've made that choice for whatever reason.
Yes, this is truly intervention level supplementation. If you're a little over 40, you've never had a DEXA scan of concern, you've never had a broken bone, there's no reason to take this. Okay. Bone base changes the recommendation there.
Got it. All right. So let's talk about medications, because you just hinted at some of that. What are the options? How does that work?
So we'll stick with kind of the common ones here. It's the bisphosphonates.
Okay.
Those are your Fosamaxes, Alendronate, Boniva. All those once a month or typically once a week type medications.
Mm-hmm.
So essentially, the molecule itself, the bisphosphonate molecule, binds to bone. It inhibits osteoclasts, so it inhibits the breakdown cells of bone in the body.
Right.
And they have been shown to reduce fracture risk by 40 to 70%.
Wow.
Okay. So they don't do a good job of building new bone, but they do absolutely slow breakdown of bones down and thus are able to reduce fracture risk.
That's awesome. Okay.
So what we touched on earlier was, adding, you typically, when you are on one, your doctor is going to want you to have the bricks. He's going to recommend that you take calcium. We would recommend bone base in that case. Still make sure that you're giving, because again, these medications, even though they do reduce fracture risk, they're slowing the breakdown down. They're not helping to build.
Right.
So you do still want something else on board. That's really the key point of why I've touched on these. So bone base is what you would go with here. You don't need the Bone Pro. It's just not from an interventional standpoint. You've already got the intervention done. Go with Bone Pro. Make sure you've got enough bricks.
Okay. All right. So we've got bisphosphonates as the primary pharmacological agent. We've got our Bone Base and Bone Pro as great supplement options. Is this all a result of just aging and, for females, it's drop in estrogen? Is that the only thing that's going on here, or are there other issues that could be at play that people need to be looking out for?
So again, just so we make sure we're covering all the important things. If you have accelerated or aggressive bone loss, your doctor's going to look at other avenues. Everything that we've discussed, that Tyler just mentioned, of what can lead to this issue with bone remodeling and why maybe you have increased fracture risk or decreased quality on your DEXA scan. All of those things are not typically going to cause a fast or aggressive bone loss. So you want to look at things like your parathyroid hormone. We touched on that some of the products and ingredients.
If you are experiencing fast aggressive bone loss.
There may be thyroid over replacement. I'm assuming you're getting checked, but all these things are just something to be aware of. Celiac disease.
Wow.
Ones that are a little more nuanced. Celiac disease can contribute here. Chronic steroid use. We kind of know that's a common issue associated with steroids. We're not trying to scare you. You get sick, your doctor recommends you take it for 5 days. We're talking chronic. That's the key word there.
And that's the anti-inflammatory steroids, not the big, huge muscle steroids.
Yes. Good one.
Just
there. Yeah.
meaning you need to be aware of that, because that's going to be much more
Good
applicable to most people.
Yes. Chronic anabolic steroid use.
Yeah.
So kidney disease. So if your kidneys are not functioning as well, there's issues with clearance of minerals, etc. So if the bone loss is aggressive, there's something else going on. We're talking about, from a standpoint of the supplements and the lifestyle interventions, things that are not included in what I just mentioned.
Got it. Okay. All right. So you had mentioned protein as being huge. That was way up the hierarchy above calcium. Why protein?
So protein is important, and it's one of those things that doesn't come to mind right away, right? You think of the calcium, you think, okay, well, now I've kind of got on board with the vitamin D, K thing. Protein now, what do you mean? So essentially what happens is low protein reduces IGF-1. IGF-1 is insulin-like growth factor.
Okay.
For the purposes of this, what that does is it's a stable, long-lasting messenger that tells your body to grow tissue and to promote bone growth. So when you're aging, that's already naturally declining. Okay, you're already assuming if you have some of these issues with bone health, you are probably not doing resistance training. Okay, so the hormones are changing on you. You're not doing the resistance training. So what can occur is that IGF-1, just based on the protein, you've already got all the other things working against you.
Yeah.
Now the IGF-1 is decreased because of the low protein. Okay. Further, muscle supports the bone. Okay. Weak muscles do have an interplay with the bone health itself, with fracture risk. Okay. So if you're low protein and you're not doing resistance training, the odds of you having good, strong muscles to help to support the bone are very slim. So there's two. There's one more physiological explanation. That's via the reducing of IGF-1.
Right.
And then you've got kind of the physical explanation.
It's like a mechanical issue.
Yes, exactly. So from both of those standpoints, that's why protein is critical. I know for me, anytime I understand why something, where you can tell me protein helps with bones, okay. But when I understand, I know for me, I'm more likely to actually, act on it and do something about it when I understand
So
it.
you said you need to have more protein because of the IGF-1 and because in general, just bigger, stronger muscles tell the body we need bigger, stronger bones.
Yes, and help literally to physically support that bone.
Amazing.
When you fall, if your bone is slightly less dense or slightly of less quality, and you have muscles to help navigate the fall, okay, just in the most crude sense, or if it's you kind of just
Or add cushion.
Yes. But so that's why that is a big just physical issue related to why bones are actually broken, why fracture risk increases.
Got it. Okay. All right. So tell me more about the hormones thing, because I think this is fascinating, the way that estrogen interplays with all of this. Give me details.
Estrogen is the primary driver post-menopause of why we see decreased bone density, why we see increased fracture rates. Okay.
Or lack thereof.
Yes. Yes.
Okay.
So HRT does improve bone mineral density, full stop. Okay.
Wow.
Now, that said, we certainly don't want to tell you that that is your answer.
Right.
Okay. But at the same time, would be remiss not to mention it. Typically, if you're in a situation where your estrogen has declined to a point where it's making a significant impact on your bone health, you may be having other symptoms. You may want to get levels checked. Risk is definitely risk benefit analysis is certainly warranted. Talk to your doctor, but it may be one of those things where, yeah, you have decreased bone density. You'd rather not go on a med yet. Potentially, you are having some night sweats, hot flashes, mood swings, etc. You've got some other things going on, so maybe you do consider get checked out. Natural, like we've talked about in other pods, but natural hormone replacement, when done properly, when being monitored, can impact the quality of your life. This is just another component to it.
Absolutely, and with the FDA removing all the black box warnings and all that stuff,
we can say that much more comfortably than we could have 2 years ago.
Yes, very, very cool.
We've always believed it and known it, but now at least there's that removed from our liability standpoint.
Yes,
you know?
the government agrees. Okay,
Yes.
so all right, so we're potentially getting labs checked for hormones. What are is there, you said a DEXA scan. Is that that's basic?
Actually the bone. Yeah, that's the basic, just bone density test.
Okay.
But one level down, vitamin D, critical to get tested. Okay, so test your 25-OHD. Also, do want to make sure, I kind of talked about how calcium deficiency, relatively rare and typically not like the cause of this issue, but yes, get it checked. Make sure that in your case that you're not one of the rarities. Okay, creatinine, you want to check your kidney functioning. Thyroid, parathyroid. Has interplay with vitamin D. And for men, I know we just talked about how estrogen is that main component, but testosterone in men, the anabolic hormone, is a huge factor as well. It's much less common in men to have fracture risk and decreased bone density. But if you are in that boat, there's a good chance that your testosterone is a major, major driver. Their lack thereof from testosterone is a major driver of why that's occurring.
If memory serves, I remember you saying in the older episode about all this, that men who do have bone density issues are more likely to have a fatal fall, that's more likely to be the cause of death. So it's a big deal. You should definitely get this checked out.
Absolutely.
Okay.
One thing to kind of tie things together.
Yep.
When I mentioned that you should get your kidneys checked, the reason is if kidney functioning is very poor, so the eGFR lower than 30, okay, you would want to avoid aggressive mineral protocols. And you would want to avoid or at least be very cautious and monitor with strontium. So strontium specifically regarding the kidneys. Again, what usually comes to mind as well, so you're mentioning minerals and kidneys, and boy, so minerals make my kidneys worse. That's not what's happening. What's happening is if your kidneys are poorly functioning already, that minerals can exacerbate things a little bit, but it is not one-to-one that they cause these issues.
Sure.
It's just you're susceptible to them because your kidneys aren't functioning like normal.
Okay.
I just want to make that clear. So be cautious with strontium, full stop.
That's the pro.
That's the pro. Just be cautious. It's really recommended just to monitor, make sure that things aren't getting any worse. Okay.
If you have kidney issues.
Yes. And then I think because the recommendation is to avoid aggressive mineral protocols, the pro bone, kind of with the strontium, that would be more termed into that aggressive because of the strontium. But something like bone base, you're getting less total minerals. Not to mention that they're different. You're getting less total minerals than if you're doing something like an osteocal. So again, that's just another reason maybe to be cautious with those mega calcium doses. So kidney considerations are a thing, especially because who's the likely target of some of these higher end products is elderly people, increased risk of kidney dysfunction.
Okay. All right. Well, let's wrap this up. You said take tons of calcium and don't worry about anything else.
Exactly.
Yeah.
Exactly.
No.
Calcium is absolutely necessary. We've covered that a few times. It's just rarely sufficient to move the needle for you because you're very rarely truly deficient. Okay.
The hierarchy you mentioned, I think, is huge. Just to recap that for folks. Yeah. Resistance training is number one. You have to do that. It is the primary thing to help your bones stay strong as well as your muscles. Protein intake is also very, very important. in relating to the muscles, it tells your body to keep building muscle and building
Muscles and
bone as well.
IGF-1
And the
directly.
IGF-1.
Low protein status decreases IGF-1. Yes.
Very cool. Okay. Hormone optimization, it's particularly for women,
But also the testosterone.
but also
in
for men.
Mhm.
Vitamin D sufficiency, magnesium sufficiency, and then calcium sufficiency.
And then the
And then
fancier
the
stuff.
specialist stuff. Okay.
Mhm.
All right.
Yeah.
So other than the hierarchy here, what are the other takeaways people need to remember?
Kind of a final wrap up. Okay. If you're in the prevention stage, okay, you don't have low DEXA scan results, no fracture, etc. Bone-based essentials. But you're getting over 40, it's becoming a concern, okay, especially for a woman. Lifestyle optimization and bone-based essentials. If you have mild osteopenia, okay, so the beginning stages, still bone-based, but make sure you get your D level checked and reassess periodically.
Got it.
If you have progressive osteopenia, so you haven't quite crossed over, but things are getting worse from where you were, I would consider and probably go with Pro Bone.
It's okay. If you have progressive osteopenia.
Yes, if you have progressive osteopenia, so things have not quite progressed and crossed over into official osteoporosis diagnosis, but there is a progression going on. Switch over to Bone Pro Essentials, okay? Absolutely. And then osteoporosis, yes, if you have full-blown osteoporosis, discuss RX therapy first. If you have made that decision, then we can provide what I think is a good supplement option for you. But if you have documented osteoporosis, first recommendation, even from our standpoint, is to go with the medication and add bone base with the medication. If you are forgoing that for your own personal decisions, then of course, Bone Pro.
Very good. Very good. If you learn something, if you know somebody who needs to hear this stuff, share it with them. Give us a thumbs up or a like first. I mean, that's easy. And it costs you nothing. Just like the show, guys. Come on. But share the show with somebody that you know, somebody you love. Certainly somebody in your life is probably over 40 and probably female. This is affecting so many folks, and it can be an enormous quality of life and life length extender. We're very proud of these products, very excited. Where can you get them? You can go to the website, askjoedimatteo.com. That's askjoedimatteo.com. That site is where you can sign up for our newsletter. Sometimes things go on sale. You can find the past episodes of this show. You can get questions answered. If you want a question directly answered, email us questions at askjoedimatteo.com. Alternatively, you can always leave a comment down below if you're not shy. We answer those there on the video as well. Anything else? I think that's it. Josiah Schweinberg, Joe DiMatteo, PharmD.
You thought I was going to say something.
I was hoping for it.
Me too.
Yeah. Just a waste.
Quiet today.
Dead air.
Sorry.
I'm Tyler Andrews, your host. Thanks so much, guys. We'll see you next time.